Tokyolive
Endoscopy
Endoscopy 1.
Hello, everyone. And this is the section that is about the cure state of the poem. Now, first of all, let me introduce the speaker and the comment and commentary. I'm Dr. Ling Hu, the president of the Chinese Society of Digestive Endoscopy, CSDE, and I'm the head of the digestive faculty of the People Liberation Army General Hospital. Let me introduce the speaker, that is Professor Inoue. Professor Inoue is a wide remote surgeon and endoscopist. He's a professor at the Showa University School of Medicine and the chairman of the Digestive Disease Center at Showa University Kato Toyosu Hospital in Tokyo, Japan. And he's the president of the GGES 2019. He's very famous. And he clinical achieved a widely ranging. In 1992, he developed a technical, let's say, the EMR, that simply performed an endoscopic mucosal resection. In 2000, he reported the world's first EMR for birth into mucosal cancer. And in 2003, he again reported a circumferential EMR for esophagus with high-grade dysplasia. This is also recognized as the first clinical report of anteroreflex sectoma, that is arms. In 2008, he performed the world's first clinical case of peritoneal endoscopic Myotomy, POEM. And to date, his term has treated more than 2,100 ecclesia patients with the POEM procedure. In 2014, he reported endoscopic removal of the submucosal tumor and using POEM-like procedure, pre-oral endoscopic tumor resection, POET. Also in 2014, he reported an arms procedure for PPI resistant GERD. Now is achieved at anteroreflex mucosal ablation. In 2019, he reported POEM and fundoplication as a per-nose surgery for PPI refractive GERD. It's very famous in the world. And next, I will introduce the Professor Fandor. Professor Fandor is a professor of the Department of Abdominal Surgery, Gastroenterology, and Digestive Endoscopy and the AI program Russian National Research Medical University, and the clinical hand of the Department of Endoscopy, Endoscopic Surgery at the Moscow University Hospital number 31. He is the advisor to scientific and practice council of the Minister of Health of Russia, the current vice president of the Russian Endoscopy Society, and a member of the several international committees and scientific societies. Professor Fandor was published more than 118 public scientific articles and several books in the area of endoscopy, and is a consultant and a reviewer for several surgical gastroenterology and endoscopy journals. And his principal research in testing included the introduction evaluation of the new intervention endoscopy methods such as ESD, POEM, STIR, clinical unity of the therapeutic endoscopy, retrograde collegial pancreatography, that's ERCP, endoscopy, colonoscopy, and so on. So now let's give Professor Inoue give us the speech.
Okay, thank you so much, so much. Thank you, Professor Lingu, for your kind introduction to us. And it's my great honor. I'm so honored to have two great leaders in the world in this session. I'm so honored. So today I would like to talk about the current status of the POEM procedure. Okay. So thank you very much. I would like to talk about the POEM and its offshoots. So this is my disclosure. So treatment for gastric surgical treatment was first reported by Dr. Ernest Heller 100 years ago. And recently on J. Pasuricher, so he reported the possibility endoscopic submucosal myotomy using POSIM model. So world's first case of a POEM was done in 2008. So that is almost 12 years ago. So this is the first case. Please note the date of the procedure, 2008, September 8. So this is a case, and in this case, we place the anterior mucosotomy and then getting a submucosal space. So after completion of submucosal tunneling, now we are starting the circular selective myotomy. So anyway, so we completed the myotomy of the lower esophageal sphincter. So at this image, the bottom is a mucosal backside, and the top is a muscle side. Anyway, we close the mucosal entry using clip. This is the world first case, and the esophageal gastric junction is already open like this. So volume throttle before and after, so going smoothly. 8 years after procedure, this is a photo. We met together, and the patient satisfaction 100%. He gained 20 kilogram, and he actually complained no GERD symptom. This is an endoscopic view 8 years after procedure. Junction is smoothly open under no reflex. So far in our hospital, this was the data last year. So now we perform more than 2,300 cases in our hospital. Indication is all achalasia, symptomatic achalasia, and also some motility disorders with a symptom of dysphagia. Okay. So this is a summary at the time over 1,200 patients. So ILP reduced the 28 to 13 after POEM procedure. No major complications. So success rate is 95% and more. So this good data is same in high volume center in the world. So, but the potential problem, so good procedure, but potential problem is the post-POEM GERD, 22 to 53% risk of GERD. So most of them are very mild and asymptomatic. So, point is how to avoid post-POEM GERD. So recommended procedure is a double scope method. Control gastric myotomy range to 2 centimeters. So this is actual procedure. We insert the two scopes. One is a submucosal endoscopy. The other one is a pediatric scope in the stomach and monitor the position of the submucosal endoscopy. The submucosal light is we can recognize it like this. So less than 2 centimeter position is the best to complete this procedure. This can avoid the incomplete myotomy of the LES and also gastric myotomy. Too excessive gastric myotomy can be avoided. This is an objective scale like this. So if in this case, submucosal endoscopy goes too distal from the esophageal junction. So if it goes more than 3 centimeter, patient becomes a higher risk, facing the higher risk of GERD. So 1 to 2 centimeter is the best position. So one doctor, so Dr. Kevin Grimes, he conducted the RCT, and his conclusion is more than 3 centimeter gastric myotomy may cause probably cause increased rate of severe esophagitis. Okay. On the other hand, this is the esophageal myotomy ranks during POEM procedure based upon the Chicago classification high resolution manometry version 3. So, but it looks a little bit complicated. So we summarized this one to 3 categories. So Chicago type 1 and the type 2 achalasia. So we place LES myotomy. It's a conventional style. It's the same to a laparoscopic myotomy. And the second category is extended myotomy including esophageal body. This is for vigorous achalasia, the Chicago type 3. And the category 3 is a diffuse spasm and the jackhammer esophagus. In such a case, we are trying to preserve lower esophageal sphincter, only dissect the esophageal body muscle layer. This is one of the sample, the case of a type 1 achalasia. Esophagus before treatment are filled with lots of food residue. So after POEM procedure, 7 days, so patient already started regular diet, but no dilation of the esophagus. So 3 months after POEM procedure, junction is open, this patient, junction is open, the grade A reflux disease, but definitely no problem because he was the very advanced achalasia. Actually, 1 year after POEM, this patient, symptom score improved to 6 to 0. POEM can be applied to spastic motility disorders, type 3 or some other. The success rate is 70 to 90%, so it's also good results. So I'd like to show you the case of a diffuse esophageal spasm. This is a very typical volume swallow image. So after POEM procedure, contrast media can pass through very smoothly. So in this case, we are trying to preserve the lower esophageal sphincter. Before treatment, high resolution manometry demonstrated the LES function is normal, so preserved. Then we try to keep untouched the lower esophageal sphincter during myotomy. Actual video. So esophageal body, we can see lots of abdominal contractions, and then creates a submucosal tunnel, and then now we dissecting the circular muscle. So this is the very end of the submucosal tunnel. You can see a thin muscle layer. This is the beginning of the lower esophageal sphincter. Then we stop the myotomy and preserve the lower esophageal sphincter muscle. Okay. Proximal side is we place the longer myotomy. This patient is 1 year after POEM procedure, symptom well controlled. So this is the current situation of the POEM procedure for achalasia patients. And next, I'd like to introduce a several offshoot of the POEM procedure. That is a gastric POEM for gastroparesis. So this is a procedure. We approach the greater curve and the inner submucosal space. We try to cut the pylorus muscle. So first POEM procedure, G-POEM procedure was done Johns Hopkins University together with Dr. Moen Kashyap and Dr. Stavros Stavropoulos and myself. That was 8 years ago. Time flies very fast. So this is the data of Moen Kashyap. Successful responding rate is 86%. Okay, so this is our patient, Japanese patient. So he has a symptom of vomiting. So we do a myotomy, pyloromyotomy in a submucosal space like this. Then at the after dissection of the pylorus muscle, we can clearly observe the duodenal muscle layer, very thin. So we can stop the pyloromyotomy at this moment. So bottom, you can see outside the duodenum, so fat tissue, no problem. So we close the mucosal entry using clips like this way. In this case, we use a loop and clips. So another application of the procedure is a POET. So this procedure is an application of the POEM to the submucosal tumor of the mostly esophagus or GE junction. So we reported this procedure to the Journal of Endoscopy 2012. Same year, Chinese doctors, Dr. Xu and Dr. Zhou, so his group reported the same procedure to a Journal of GIE 2012, same year. So many American doctors call this procedure STAR procedure. Okay, so same procedure. Anyway, so injection, so that creates a submucosal tunnel, and then inside the tunnel, we approach to a surface of the tumor. And after mobilization of the surface of the, after dissecting the surface of the tumor, after that, we approach behind the tumor. Then, so this tumor is connecting to a longitudinal muscle layer as well. So we have a big defect of the muscle. So in this case, the tumor was taken out using the snare wire through the mouse. Okay, so after this, so big defect of the muscle layer, but we close the mucosal entry using clips, so definitely no problem. So finally, I would like to mention briefly about another technique to control the post-POEM GERD. That is a or endoscopic fundoplication. So as you may know, laparoscopic treatment for achalasia, when we perform the HERA myotomy, after that we add the anti-reflux procedure. So that is the DOE, anterior partial fundoplication. So now we can do it using the oral flexible endoscope. So first case was done in the 2017. So far, we did 45 cases. This is a live demonstration at the time of ESGE days in the Prague, 2019. Okay, so we place the anterior submucosal tunnel on the distal end of the submucosal tunnel. We get in abdominal cavity, and then catch the anterior wall of the stomach, and then make a fundoplication, put the fundoplication onto the abdominal esophagus. So this is the first case. So this is an anterior wall approach in the submucosal tunnel, distal end of the submucosal tunnel. Muscle has already been dissected. Now we are approaching the peritoneum. And behind, we can see back side of the left liver alone. So now we are dissecting the peritoneum. And then we get in abdominal cavity, our CO2 insufflation. And then, we place a double intragastric scope and then insufflate to keep the tension to the surface of the stomach wall. And now we place the full layer suture on the anterior wall of the stomach. This is an intragastric scope view. A needle is coming in the lumen and going out. So please also note, so after POEM procedure, junction is open this case. So this is a proximal anchor. We place a suture onto the right limb, right crush of the diaphragm. Then we pull the V-lock. We can make fundoplication like this way. This endoscopy image is very similar to our after Dove fundoplication. So this is the data. At the time of 43 cases, a technical success rate at 100%. And a PH study demonstrate better results in a fundoplication group compared to the POEM alone group. So now the treatment strategy for achalasia patient is like this. So this is the last slide. So achalasia patients, so we routinely standardly perform the posterior myotomy and the POEM alone. So so using double scope technique, we can avoid the severe reflux as small number as possible. And the only less than 1% of the POEM cases become the refractory GERD. That means grade C/D GERD. So in such a case, we perform a power endoscopic fundoplication in anterior wall of the esophagus. Not the last slide. This is really a last. So Nissen fundoplication is very strong. The Toupet is also, Dole is a mild fundoplication. POEM is also a mild fundoplication. So thank you very much for your kind attention.
Thank you very much, Inoue Sensei, first of all, for all your innovations in our field and for your comprehensive lecture. You know that all over the globe, more and more people follow your steps. And of course, we prepare for you some questions for which you already answered. For example, we would like to ask you what exactly determines the optimal length of myotomy in the esophagus when performing POEM, but you already explained it for according to Chicago classification. And we also would like to ask you what are the technical tips and tricks for performing POEM in the area of the lower esophageal sphincter and cardia. Maybe could you please a little bit emphasize it once more, how to preserve the slim muscle and what about penetrating vessels in this area?
So thank you very much, Dr. Fyodorov. It's a very, very important question. So Western endoscopists, they did lots of, actually did lots of POEM procedure, but they talked to us, they have lots of severe reflux disease in the POEM patient. So, but actually, in Japan, we don't have not so many severe reflux cases. What's the difference we are thinking? And then, so one arm is we conducted the RCT, and the Dr. Kevin Grimes, he came to our hospital, he organized it and conducted it, and resulted if we dissect more than 3 centimeters in a gastric side, place a myotomy, longer myotomy. So the potential risk is the color swing muscle. That is anatomical important factor to create the angle of hairs. Angle of hairs is made of swing muscle. The radius of a swing muscle is 4 centimeters. So when we place more than 3 centimeters gastric myotomy, so almost all the color swing muscle is cut down, so cut out. Then so his angle is originally sharp angulation, but so his angle lose the sharp angulation and become a kind of a hiatal hernia. Then the patient may become a severe reflux. That's a mechanism. So we think it's better to control the gastric myotomy range less than 2 centimeters. So, but how to control the 2 centimeter gastric? That is a clinical, technical question. So, in order to get the objective information, we started double scope technique. So, so using the intragastric monitoring endoscope, we can see accurate position of the submucosal tunnel distal end. Then we can control the gastric myotomy length very well. That is the background. So anyway, yeah, we can control the severe reflux disease.
Thank you very much, Inoue Sensei. Another question, if possible. We often discuss with our surgeons the situation about the terminal stage of achalasia. What do you think about 2,000 cases, your personal experience or experience of your hospital? Is it possible to start from POEM, or there are situations when it's necessary to remove the esophagus immediately without so-called POEM trial? If yes, when? Could you please?
So, Dr. Hyodo, sir, thank you again. And this is a very, very clinically important question. So, some achalasia patient has a longer history than 30 years, and the patient esophagus, the thoracic esophagus is totally dilated, type 1, but the end stage. So it's a huge, like a stomach-like esophagus. And in such a case, treatment option, so conventional surgical myotomy will not work. So, so how to manage such kind of patient is of course, esophagectomy is one of the treatment option for the patient, but esophagectomy is a very invasive surgery, particularly long-term suffering, achalasia suffering patients. His or her nutritional condition not so good. So in such a case, surgical esophagectomy should be last choice. So our position is like this. So we recommend pneumatic dilation of the junction or POEM to the patient. Of course, we have to talk to the patient. We try to do the POEM, but no guarantee as a result. But So if it's effective, so yes, half of the patient is poem or pneumatic dilation is effective. So in such a case, we can preserve, we can avoid esophagectomy. So anyway, we do some mini-invasive treatment, such as balloon dilation or POEM procedure. So if we failed the POEM or balloon dilation, so we talk to the patient and the patient family, only treatment option, remaining treatment option is esophagectomy. The another problem is I'm a surgeon, so esophageal surgeon. So esophagectomy, so very advanced achalasia, is very difficult. So reason why? So when we approach trachoscopically, esophagus is like American football. So it's impossible to mobilize the esophagus using a 5mm or 10mm of devices. It's impossible. And then, of course, a specimen itself is huge, so like a football. So, most of the case we have to open chest. And the intratracheal anastomosis is also very difficult because in such a patient, esophagus is self-dilated. So adjustment to the gastric tube is very difficult. Technically difficult. Some patients have leakage after surgery. It's a very serious complication. So like that. So esophagectomy is a last choice. Last choice.
Thank you. And if you don't mind, one more question. We have a great debate with our oncologists about removal of gastrointestinal stromal tumors using the POET endoscopic approach. What's your opinion? Is it possible to remove localized GIST using the endoscopic POET procedure?
Yes. You are talking about the indication of a POET procedure to GIST.
Mainly for GIST, yes.
So yes. Thank you very much. So this is again, it's a very important question. So using a technique of a POET and a STAR, we can resect the submucosal tumor, particularly in the esophagus and the esophagogastric junction. So we can resect it. So Dr. Zhou in Shanghai and the Dr. Philip Chu in Hong Kong, they are also, two of them reported a big number of data of the STAR and the POET. So our data is also same. So application of the this endoscopic resection, the tumor size is less than 4 centimeters. Huge, more than 4 centimeters, large tumor is technically difficult to complete. So we can challenge, but we have to talk to the patient the potential risk of conversion to surgery. And so that is a size limitation of the procedure. And another discussion is application of this procedure to GIST. That is a middle level malignancy. So application of this endoscopic approach is not yet concluded. But personally, I think we can apply this GIST is one of the best application of this procedure. So of course, size limitation is the same. But for example, best indication of this procedure is a 2 centimeter submucosal tumor GIST. So FNA then identify the GIST. So in such a case, we have to treat the submucosal tumor. But so trachoscopic approach and the laparoscopic approach is too much. So 2 centimeter gist in the esophagus is a definitely indication, and the GE junction as well, and even in the stomach, 2 centimeter gist tumor is a good application of this procedure.
Sensei, unfortunately, the time is going on. Thank you very much for your open and very open-hearted answers. And stay safe, and hope we will see you personally soon. Thank you very much, and all the best for Tokyolive 2021.
Okay, thank you, Professor Inoue, and thank you, Professor Fender. And about this section that is about the poem. Actually, Inoue is the father of the poem. I know that is. We performed the first case of the ESTD 2009. I defined that is the therapeutic, the dental endoscopy tunnel technique.
Yes.
First published 2013, and then the second is published is 2020. And actually, the first cases I published the submucosal tumor from a tunnel technique and to treatment of the submucosal tumor, and 2011 and in Chinese, and I just in an animal model that's successful. That's the 2012, and Dr. Xu published that is said as stir.
Yes.
This is a very good the time that is a lot of innovation. Actually, Inoue do a lot of development in the digestive endoscopy surgery, and we established a new committee that under the WU, that is super minimal invasive surgery. That's another name is SMII, SMIS. I invited two of them to join us. That is, we perform the operation, but not remove the organ. That is the aim of our committee.
And the pleasure
So I invite you
to join your project.
Join us. Thank you, everyone. This is very good and the suggestion about the poem. Thank you.
Thank you so much, Dr. Rindu and Dr. Fyodorov. Thank you so much.
Okay.
Thank you.
As always.
Bye-bye.
Thank you. Bye-bye.